when we did your testing, you are negative for CMV, which means you've never been exposed to that particular virus. This is really common. We know that about 80% of people are positive for CMV, meaning that they have been exposed.
Mm-hmm.
But what we found when we did a study when I was a fellow was that my lesbian couples actually have much lower rates of CMV positivity than the general population. So it's well less than 50% of lesbian women are positive for CMV. And it makes sense when you think about the fact that CMV can be transmitted via sperm. So for women who have lots of male partners, they're much more likely to get exposed. If they didn't get exposed as a kid, they get exposed as an adult when they're having sex with a man. My lesbian patients aren't having a lot of sex with men, and so they're not getting that exposure.
Yeah.
And so the only time you had really to get exposed was when you were a kid. And you just didn't, and that's no big deal. But what it means is you should choose a donor who's CMV negative as well, because you don't want to get it from the donor sperm.
Gotcha.
The reason being, if you get it when you get pregnant, it can cause problems for the baby.
Okay.
So if you were to come down with CMV tomorrow because you happened to just catch it on the street, right? Somebody had what you thought was a cold and you got it. That would not be a problem. But if you get it for the first time when you're pregnant, then it's a problem. So that's why we have you choose CMV negative donor.
Gotcha.
So we put the eggs and the sperm together. We'll let the eggs fertilize naturally, and then we're going to grow them out till they reach the blastocyst stage. Once they reach the blastocyst stage, we would, Tara, you can decide if you want to do a fresh transfer or if you guys are planning to do, if you still want to do the family balancing. Is that something that you guys are still interested in doing, looking for a little girl?
Yes.
Okay, so then what we'll do is we will biopsy the embryos and then freeze them.
Okay.
And then it takes about 2 weeks after the embryos are biopsied to get the test results back. Once we know what we've got, we will get you started on a birth control pill so that you can move through the frozen embryo transfer process. And that's where you'll actually get pregnant. That's where we need your vitamin D needs to be normal by then.
Okay.
That process is birth control pills typically for at least a month. Certainly you can start them earlier if, for like kind of timing and stuff like that. But at least a month of birth control pill. And then you stop the pill, you have a period, and we put you on hormones that are going to mimic the natural levels of hormones for a menstrual cycle. So you're going to start estrogen pills and patches alone for about 2 weeks. At the end of the 2 weeks, we're going to do an ultrasound to make sure the lining has thickened the way it's supposed to.
Mm-hmm.
If everything looks good, we have you start progesterone injections and vaginal suppositories. And you would do that for 6 days. On the day that you take your 6th injection, we would thaw and transfer the best female embryo. And then we would have you continue those medications for another 10 days.
Mm-hmm.
At that point, we would check a pregnancy test. And with a positive pregnancy test, we'd have you continue those for another 6 weeks.
Gotcha.
At that point, it's safe to come off all those hormones and just be a normal pregnant lady.
Okay.
Okay.
Awesome.
So let's see, Caitlin, because Caitlin, you still 34?
Yeah.
Okay. So at age 34, I'm going to expect that anywhere from half to 3/4 of the embryos that you generate should be genetically normal. So if we can get, let's say we get 12 eggs from you and maybe we end up with 3 to 4 embryos, the chances are that you guys will have a couple of normal embryos and hopefully one of those will be a little girl.
Awesome.
Yeah. Couple of outstanding things for you, Caitlin. The prolactin. I know that we think that this is probably due to the medications that you're on. But I definitely want to make sure that there's nothing that we need to worry about. So we had talked about maybe doing a pituitary MRI.
We did that last week.
Did?
Mm-hmm.
Oh, okay. I just don't have the results back yet then. Okay. I'm going to make a note. Thank you. So that I can check up on that. It usually takes
We
a little.
actually have the CD.
I want to say we have the CD if you want me to drop it off at the office as well.
That's okay. Actually, thank you for getting it, for offering. Pituitary MRIs are not one of the MRIs that I read. Like I read pelvic MRIs all the time for fibroids and stuff like that, but I don't read brain MRIs. So I'll just take the radiologist's word for it.
Okay. Okay.
So let me put down that you did a pituitary MRI last week.
Yep.
And I'm going to have UC look into records for me.
Yep, the 17th.
But I'm surprised you don't have the results yet.
3/17.
I know.
Will obtain results. I'm going to have UC get them for me.
Okay.
We did it.
Where did you have it done?
At NSI, neural something imaging. Is it neural skeletal imaging? Is that what the name is?
I think it is.
Oh, perfect. Done on the 17th. That was a happy St. Patrick's Day, wasn't it?
Neuroskeletal imaging of Melbourne, right on Harbor City Boulevard.
Okay, great. Of Melbourne. Okay.
And it was done the 17th, just in case you needed.
Perfect. We're good there. So let's see, you got that. Hep C was negative. Your repeat metabolic panel was, repeat CBC was normal. TFTs were perfect. Yeah, so basically all the rest of your testing looked great.
Awesome.
So your TFTs were normal. Okay, so basically what we're going to do is I'm going to get a protocol together for you guys in terms of how to stimulate Caitlin best. Caitlin, I'm going to have you meet, as I mentioned, with our senior nurse anesthetist so that we can just make sure we've got a plan and see if she wants your pain MD to weigh in or if she feels comfortable that we can manage your pain post-operatively, without anything else. I would probably mention, when do you see your pain doc next?
She just saw him.
Yeah, I just seen him in 6 months.
Did you mention to him that you were going to be having an egg retrieval?
I don't think so.
Okay, who's your pain doc?
Michael Esposito.
And where is his office?
He just moved down to it's like an hour away, or 45 minutes.
Is it Vero?
He's in Vero?
Mm-hmm. Yeah.
Okay, great. So I'm going to give him a call and just see if there's anything that he recommends.
Okay.
Okay. So then the final thing I need you guys to hear from me, and this will be in the consent forms that you'll sign from the IVF process as well. But basically, I like to talk with couples about what the risks of IVF are. So I think of them as kind of falling into 5 different categories. The first category is the one that I think most women intuitively get. It might not work. Now, given your ovarian reserve, your young ages, your prior fertility, I guess I would probably say it might not work the first time. Right now, it could work the first time, but you're someone where, like, just going into it, it's not like I'm thinking in the back of my mind, oh, this is never going to work. No, that's not it. I'm just thinking if it doesn't work the first time, it might take a couple of cycles, sort of thing. But basically, there's different points where I may say to you, this isn't going the way we're expecting. So like during Caitlin's stim, maybe we find out that only 1 follicle is coming up, but antral follicle count is ranged between 10 and 16. And so I know she can do a lot better than that. That's a situation where I'm going to say, let's stop. Let's have a period. Let's start over. Let's use different medications. Let's modify the protocol and see if we can't get better stimulation. Mm-hmm. Sometimes everything will look good from a stimulation perspective, but we don't get the number of eggs we expect when we do the retrieval, or maybe the eggs don't fertilize as well as we would hope, or the embryos simply just don't grow and we don't get any embryos to biopsy, or we get embryos, but they're either not normal or they're not the desired gender. So those are all different points where I may say to you, hey, this might not work. And then when it comes time to put the embryo back, there's always a chance, it's about 15 to 20% chance per cycle that the embryo just doesn't stick, even though we know it's normal. But that means that we've got an 80 to 85% chance that it will stick. So overall good odds once we get that normal embryo. Mm-hmm. Second category of risks, now these are mostly for Caitlin. Second category of risks are the risks of doing the stimulation and retrieval. So there's a risk of bleeding. There's a risk of infection. There's a risk of damage to anything inside the belly. The most commonly injured sites are bowel, bladder, blood vessels, nerves, and the ovaries themselves. The chance of something happening is less than 1%, so it's not very common. But if you are experiencing something that feels wrong, it doesn't feel like what you were told to expect, I would rather have you call us and have us say, oh, no, we don't think this is anything, than miss something important. Okay. Gotcha. Third category of risks are the risks of the long-term risks of doing the stimulation. Basically, what we're looking at is there an increased risk of cancer associated with women who've done IVF? And it's primarily the ovarian stimulation that is the concern because those hormone levels are significantly higher than normal. So we've looked really carefully at this, and what we found is that about 1 out of every 1,000 women who go through IVF may experience an increased risk of a breast precancer or an ovarian precancer. The breast precancer is called DCIS, ductal carcinoma in situ. The ovarian precancer is called a borderline tumor. The good news about these tumors is that they are very curable if they're caught in the pre-cancer stage. And so it's really important that women who go through IVF see their gynecologist every year for a pelvic exam, a breast exam, make sure they get their pap smear, make sure they get their mammogram once they're old enough. Because if you do end up being that one woman in 1,000, let's catch it while it's still a precancer so that it can be treated and cured. If you're somebody who goes 5 or 10 years between visits, there might be a problem. Like maybe it was a precancer, but by the time you find it, it's already progressed to cancer. Mm-hmm. The fourth category of risks are risks to the baby. Babies born from IVF are just as smart. They grow just as tall. They're just as fertile. They're normal kids. There's no increased risk of childhood cancer, no increased risk of autism, schizophrenia, or mental illness. There may be an increased risk of birth defects, but that is primarily associated with couples who are doing IVF because the male partner has very low sperm counts. That is not the situation for you guys, so I would expect you to have the background rate of 3 to 4% risk of birth defects. Final category of risks are the ones we don't know about yet. Babies born from IVF are, the oldest baby born from IVF is in her 40s. So I don't know what happens when babies born from IVF are in their 50s or their 60s or their 70s. We just don't have that yet. So make sure that your kiddo knows that she's born from IVF so that down the road, 20, 30 years from now, if something pops up, she'll know and her doctor will know to let her know so that she can be proactive about any types of screening that needs to be done. We're not anticipating something to come out, but I'd rather be safe than sorry. Mm-hmm. And then in terms of the genetic testing, it's important to recognize that the genetic testing is not perfect. It's 98 to 99% accurate, which is pretty good unless you're that 1%, right? Mm-hmm. So what I tell people when they're doing family balancing is go into it thinking, okay, we've got a 98 to 99% chance of having a little girl. There can be errors that allow the gender to get confused, or there can be errors that result in an embryo that is actually not normal being transferred with all of us thinking it's a normal embryo. The way these errors occur, you would think that the most common reason for it would be human error. Human error does occur even though we do everything possible to make sure that we're minimizing the chance that it happens to you, right? Our embryologists use a double process. So when one embryologist says, oh, this is such and such an embryo, another embryologist looks at it and says, yes, I agree. Everything that can be automated is automated because that decreases the risk for human error. The more common reason for these errors has to do with the way the test is run. The test is tiny little probes that bind to different parts of the embryo's chromosomes. And then the test counts the probes. And if it sees the right number of probes, it says all the chromosomes are there. If it sees too many probes, it knows that the embryo is abnormal because it's got too much genetic material. If it doesn't see enough probes, it knows that it's abnormal because it doesn't have enough genetic material. The problem is the probes have spaces between them. You can kind of think of them as being like little Velcro balls on a dartboard. There's little spaces in between, and those spaces contain genetic material. So there could be small deletions or duplications or mutations that could get missed simply because the probe didn't bind in that area. The other thing is it can't pick up structural rearrangements if like the top of one chromosome switches places with the top of another chromosome. That's called a balanced translocation. All the genetic material is there, so the test correctly says all the probes are here. The problem is when that child goes to have children herself, she's going to be at increased risk of recurrent pregnancy loss because when her chromosomes try to separate to make eggs, or if it were a boy to make sperm, they don't separate normally. And so they have higher rates of abnormal eggs and abnormal sperm compared to the general population. It also can't pick up something called uniparental disomy, where both of copies of one chromosome come from either the egg or from the sperm. It's supposed to be one from each. And so you can imagine if both copies came from the egg and none from the sperm, that's a problem. And those kiddos have issues. But unfortunately, this test can't pick that up because all it can see is, oh, there's two copies. The good news is that particular disorder is very rare. The final thing is something called embryo mosaicism. This is the naturally occurring phenomenon. About 10% of human embryos are mosaic. The test can pick up embryo mosaicism if both cells are represented in the sample that we've taken. The problem is all the cells look identical under the microscope. So when our embryologist does the biopsy, he or she does the biopsy and removes a couple of cells from the safest area of the embryo. Sometimes the cells that they take out aren't representative of the entire embryo. So like maybe they take 2 or 3 cells and they're all normal, but the majority of the embryo is actually abnormal, or vice versa. That's how the test can get it wrong. Now, if the test recognizes, oh, there's actually two types of cells in this sample, it will let us know and say, we think this embryo is mosaic. Mosaic embryos are considered quasi-normal. There have been children born from mosaic embryos, but we don't know what the risks to those children are. So right now, we're not transferring mosaic embryos, although we are urging our patients to keep them because we think that the data is going to be coming out soon, letting us know if it's safe. There's a big study going on at Stanford right now looking at exactly this. So hopefully in the next couple of years, we'll have more information. Okay. Trying to think if there's anything else I needed to tell you about the genetic testing. No, that's it. What questions do you guys have?
I have a few. So
okay,
we signed up with bundled. So the bundle program, I know you said that maybe the first time it might not take. What would be your opinion? Should we go for it? Well, they have the S on the 2, like if we wanted the 2 transfers. Do you think it's smart for us to do 2 transfers or 3?
Transfers or retrievals?
So once you do the retrieval, so with the bundle program, they do the full transfer. So if you have multiple eggs, they can transfer up to, we can do the transfer into me of the eggs that Caitlin already has, up to 3 times.
I would be more concerned, in all honesty, that you might need to do multiple retrievals in order to get the normal embryo. Okay. So I know there are some bundle packages where you can do like 2 retrievals before you ever do a transfer.
Gotcha.
That might be the one that you guys want to look at.
Okay.
Yeah, because I'd be more concerned that we do a cycle, we don't get a normal female embryo.
Gotcha.
And then we're looking at doing another retrieval before you get ready to do the transfer.
Gotcha. Okay.
Yeah.
And so we're headed to, I guess, at this point, to order our sperm because like literally it just goes off the shelf like insanely. It's like houses is like sperm. Like you can't find one right now. So
oh my gosh, that's too funny. I didn't realize that sperm was in such demand.
Neither did I. So you're actually looking for it.
Let me find Caitlin. I gotta find your semaphore. Okay, so Caitlin's semaphore is positive for spinal muscular atrophy.
Yes.
Which means that you're gonna want to make sure that your sperm donor is negative for that.
Gotcha. And I have it delivered to the Jupiter location, correct?
Yes, you would have it delivered to the Jupiter location.
Awesome.
And then let me switch over. Now, Tara, you are never planning on using your eggs with this donor, correct?
No.
Okay, so then we're all good with that too. Just making sure, because if you were like, well, we might want to have another baby, and that time we'd use my egg, then I'd be like, okay, let's pick a donor who's negative for SMA and the stuff you're positive for.
Nope, this all Caitlin.
Okay. Love it.
Also, so I know we were speaking about her getting like her shots and hormones for her. When does that start? I know she has to meet with the RNA, I think. But
right, so she's gonna meet. Usually it's by phone. Okay. With a CRNA. Her name is Lavilia. She's awesome. And then I'll also talk with Dr. Esposito to just see if he has any recommendations for things that we could do. And the next step for you guys is Carly's going to start getting stuff set up for you.
Okay. Oh, okay. And also about that procedure that I was supposed to have is
right. So you're going to need a hysteroscopic polypectomy. We can do that at any point while Caitlin's going through her stuff.
Okay.
Because basically I want it done before you start your part of the cycle for the frozen embryo transfer.
Gotcha.
So but at the same time, I don't want to give you so much time that we do it and then it's 6 months later and now you've grown another polyp.
Exactly.
Right. So that's why I'm thinking I kind of want to do it like as we get close. So usually when I do these is we get the embryos, the testing results are back, we're good, you're on birth control pills, you know that your cycle's coming up and we've got 3 weeks or 4 weeks before you get ready to start your actual transfer cycle. Mm-hmm. That's usually the point where I do the hysteroscopy DNC.
Gotcha. Okay.
Yep.
Okay. So what is our timeline for Kate? I know my part is a little bit later in the field.
Yeah. So Carly is gonna get you guys set up from a timing perspective in terms of the IVF because she is one of the keepers of the calendar. Gotcha. I know where my patients are, but there are other doctors' patients who feed into the calendar where I don't necessarily know where they are in their process. Mm-hmm. And one of the things that makes our labs so good is that we are really careful to make sure that we don't overwhelm them with too many embryos at once.
Gotcha.
So if we make sure that their workload is appropriate, they can give us 100% every time. And that's what I want for my patients. So we limit the number of patients who can do a stim start at any given time to make sure that we don't overwhelm the lab.
Okay.
So Carly has that calendar and she can help you guys figure out when the stim start would be.
Perfect.
Yeah.
And we order the medications, right? We get our own medications, correct?
You would, okay. Well, she would order them for you, but you guys would purchase them.
Okay. And what if I wanted to use a different pharmacy? Because I have.
You can totally use a different pharmacy. Absolutely. Okay, so negative for SMA cents. Oh my goodness, I can't type today.
So with all the test results and everything, what do you think our success rate is?
So, assuming that we get about 12 eggs from you, that means that I'm going to expect that we would hopefully have 3 to 4 embryos to biopsy. So I think we have a reasonable probability of getting 1 to 2 euploid embryos per cycle, which means that there's a reasonable chance, I would say greater than 50% chance that you could get a genetically normal female from your first cycle. If you guys weren't doing gender selection, I would say that I think your chances of success are higher than that, because I think the chances of getting a normal embryo are actually pretty good. It's just that we know that it's going to be a 50-50 shot on whether or not it's a girl. Now, you guys certainly are allowed to say, you know what, all we have are boys, we want a boy. You can totally change your mind. Mm-hmm. But I understand sort of what your goals are. And so that's why I would say it's a little bit lower than average, only because of that.
Gotcha.
Yeah.
And
what other questions you guys have for me?
Does Caitlin have to get injections in the butt?
No, you get the injection. Well, she'll get 1 injection in the butt. You're the one who really gets the injections in the butt.
Oh, wonderful.
Yeah, sorry.
Well, I think I'd take it better than her. She doesn't like needles. So it's
Don't
fine.
worry, I'll shoot you up.
Awesome. Okay.
Yep.
I think that was all. And again, I could use any one of the sperms, the IVF, ICI, or IUI.
You can use any of them because, Yep, absolutely.
That helps me. Okay.
Yeah.
So once we get it, we ship it to the Jupiter office?
Yeah, so the first thing you're going to do once you found a donor that you like, you're going to send the information to me and to Carly.
Okay.
You guys have my email, right?
Let me get your email again. I do have Carly's. We actually talk a lot through email.
Good. Good. My email's super simple. It's Dr. McCarthy, Dr.McCarthy.
Okay.
At ivfmd.com.
And I do get put to sleep during the...
You do. You get propofol.
That's fine. Whatever.
Just say anything. Just anything.
I have bad anxiety. I can't do that up.
Gotcha.
I'll be there. Am I able to be there while they're doing the retrieval?
Not in the room during the retrieval because she's being sedated. Oh. So it's like an OR.
Yeah, I know.
Yeah.
I know she's out. Well,
she's out.
Can I be there waiting for her?
Absolutely. Like you can be in the office. You just can't be in the room where I'm doing the retrieval. And then once the retrieval's over, you could sit with her in recovery.
Okay. Okay.
Yeah.
Oh, okay. Okay. Got you.
Yeah.
Now with the retrieval, do we do that in Viera or do we have to go to Jupiter? Oh, okay.
That would be in Jupiter, because that's where our lab is. So everything else can be done in Viera, but the retrieval and the transfer have to be done in Jupiter.
Okay. Which is not a problem. Not a problem at all. I think that was all my questions. Yeah. Okay, so we were looking at, I know when we spoke last, we talked about a possibility of that July time frame of, hoping to be pregnant. Do you still see now that you've gotten more evidence of like our labs and, I know the MRI
I do think it's possible because so basically we would have to have embryos by June in order for you to be able to go forward with a July cycle. And I think that that's reasonable because that would give us time for at least 1 retrieval, possibly 2. Now, one thing I want to mention to you guys, so we do our batches in Jupiter every other week. There is one batch where I'm not going to be there. This is the only time, honestly, in the 10 plus years I've worked for this company where I'm not going to be here for a batch. So I'm letting all my patients know ahead of time. You still have the option to go forward with the retrieval, even though I'm not there. So like, if you're looking at your schedule and you're like, this batch works best for us, we want to do it, you're allowed to choose that batch. But I need to be totally transparent with people so that you don't go down to Jupiter thinking it's going to be me. Hold on just a second.
So when you say that batch, like you doing a procedure or
hold on one quick sec for me.
Okay.
I got the next patient is texting me and I'm just letting her know that her system is working fine. Sorry, I can't type and think at the same time. So basically, if you decided you wanted to go forward with that batch, what would happen is you'd still do everything in Viera, but when you went down to Jupiter, it would be one of my partners, right? And I don't want that to be a surprise for somebody. So if somebody willingly chooses that knowing, oh, you know what, she's not going to be around, but this works better for us and I'm asleep, so I don't really care, that's fine. On the other hand, especially for patients like you guys where you've got a lot of complex stuff going on and Caitlin has anxiety.
Yes.
It might feel a lot better if when you go to Jupiter, it's me walking into the room and not somebody you've never met.
Exactly.
And so one, I'm always square with my patients from the beginning of something, if I can predict something ahead of time, like me being out of town, right? But number two, you're the last patient that I would want to have that kind of a surprise, like, whoa, I thought it was going to be this person and now it's not.
Yes. Okay.
So yeah, so so that particular batch it would be stim start at the beginning of May, with retrieval mid-May. I'm back for the next one, which is stim start mid-May, retrieval end of May, and I'm here for the one before that, which is stim start mid-April, retrieval beginning of May. So it's only that there's 3 retrievals in May, and that's why it ended up being all messed up.
No problem.
Okay. I think that was it. What other questions do you have?
Baby, do you have any other questions? I think I'm good on my end.
No, I'm good.
Okay, cool. So I'm going to reach out to Dr. Esposito.
Okay.
Let me write down here, Dr. Michael S.
And I'm going to get that pill today too.
In Vero. Okay, so perfect. I'm going to do that. And we're going to get that pituitary result from your MRI to figure out what the heck is going on.
Awesome. And I'll reach out to Bundle today, just so
I love it.
I can get them all squared away because I want to make sure everything's taken care of.
Love it. All right. Why is my computer frozen? Save, close. All right. Cool. You guys, I'm so excited for this.
Awesome. I'm super excited.
This is going to be awesome. All right. So if you've got my email now,
Yes.
If you think of a question, feel free to shoot me any questions, CC Carly on them so that she and I aren't talking at cross purposes.
Okay.
But then I'll be seeing you guys really soon.
Awesome. Thank you so much, Dr. McCarthy. I'm excited.
All right, guys. I'll talk to you soon.
All right. Talk to you soon.
Bye.
Bye.